Hello students, welcome back to Anuraja Nursing classes. I hope you all are doing well. So today we are going to discuss about cancer of the oral cavity. Okay, so we are going to introduce the oral cancer, its definition, what are its causes and clinical manifestations. We will discuss how we can diagnose the oral cancer. Then we will discuss about its management, and basically we will focus on nursing management because we are nurses, right? So let's move on. So, cancer of the oral cavity are associated with the use of tobacco and alcohol as it seems to have a synergistic carcinogenic effect. Okay, so those who are taking tobacco and alcohol together, they give us synergistic carcinogenic effect. Means if someone is taking tobacco and alcohol, so the cancer antigens will be more sensitive towards the alcohol and tobacco and they will cause cancer. Okay, more commonly after the age of 35 years with 65 years behind the average age of diagnosis. In between the 35 years and 65 years, we are getting oral cancer more commonly. Okay, so oral cavity cancer is 2 times more common in men than in women. Okay, why? Because men are more prone to tobacco chewing and alcohol consumption. Okay, so the common sites, what is the common site of oral malignant lesions are lower lip. Okay, mostly the lower lip. Firstly, lower lip will be getting cancer, then the metastasis occur and it spread to the whole mouth, oral cavity, and then it further spread to the nearby organs of the respiratory tract. Okay, so lateral border and undersurface of tongue maybe get carcinogens, and then labial commissures. Labial commissures are the where the two lips are attached together. This is a labial commissure, and we will get, the cancer can be occur in the buccal mucosa. So the National Cancer Institute defined oral cancer is as the cancer that forms in tissues of the oral cavity, the mouth, or the oropharynx, the part of the throat at the back of the mouth. Means National Cancer Institute not only defined oral cancer as a mouth cancer or oral cavity cancer, but also it includes the oropharynx cancer. Okay, and according to FDI World Dental Federation, oral cancer is a type of head and neck cancer and is any cancerous tissue growth located in the oral cavity. Okay, so oral cancer we are discussing, oral cancer is not limited to only oral or oral cavity. Okay, it is also included the oropharynx cancer, means neck cancer also. Okay, oral cancer is defined as the abnormal uncontrolled growth of cells in the oral cavity characterized by lesions, छाले पड़ जाते हैं, thickened mass, a mass thickened will be there, okay, and dysphagia, difficulty in swallowing. So what are the types of oral cancer? So we already know that oral cancer is not limited to oral cavity. Oropharynx is also included in it. So here we are dividing the oral cancer into two types. Firstly, oral cavity cancer, which starts from the mouth. Okay. And the second is oropharyngeal cancer, which starts in throat behind the mouth. Okay. So, and third is head and neck squamous cell carcinoma, short form in we can tell HNSCC. ठीक है, is a term used for the cancers of oropharynx, means oral cavity and pharynx, and larynx, and it accounts 90% of malignant tumor. मतलब head and neck squamous cell carcinoma accounts 90% of malignant tumor which can be spread nearby the organs. Next, what are the main causes of oral cancer? Okay, so कारण क्या है oral cancer होने का? तो first of all, the exact cause is unknown. See, in many of the diseases, you will get the exact cause is unknown because there is so much to discover till now. Okay, so second is long-term use of tobacco. That's why we are getting more oral cancer in men. Okay, History of frequent alcohol consumption, those men or women who are frequently consuming the alcohol, they may get the oral cancer. Okay. Prolonged sunlight exposure may lead to lip cancer, because if we are exposed to sunlight in a prolonged period, then what will happen? The UV rays directly mutate our cells and we can get lip cancer. Okay. Next, irritation from the pipe stem resting on the lip in pipe smokers. Those who are smoking from the pipe, means those who are taking that hookah types, tobacco hookah, those who are taking, they are taking from the pipe. Okay, so that pipe irritation can cause lip cancer. Okay, next, HPV contributes 25% of oral cancer cases. Human papilloma virus, okay, which is the main cause of cervical cancer, can also cause oral cancer, and its percentage is only 25%, but yes, 25% is much more than 0%, right? So HPV can cause oral cancer. Multiple oral sex partners, if the person is having multiple oral sex partners, then also he can get what? Oral cancer. Next, low serum vitamin A, C and E levels. If we are not consuming vitamin A, C and E appropriately, and minerals, and even our balanced diet is not maintained, we can get so much diseases, including oral cancer. Okay. Smoked meat ingestion, if we are preserving the meat by smoking method, then after that if we are eating frequently or in a long period of time, then we will get oral cancer. Next, poor oral hygiene, if we are not maintaining our oral hygiene, then only we can get oral cancer. Recurrent herpetic lesion may lead to lip cancer. If we are recurrently getting infected from herpes virus, then also we can get what? Lip cancer. Next, immunosuppression, if we are immunosuppressant, or if our immune system is suppressed due to so many conditions or due to so many problems, like we are using immunosuppressant drug because of autoimmune diseases, or our immunity is suppressed by birth also, in that time of cases we can get oral cancer. Next, syphilis, if we are infected from syphilis, at that time also we can get oral cancer. Next, chronic irritation, jagged tooth, ill-fitting prosthesis, chemical or mechanical irritants. These are causing chronic irritants. Like these are chronically we are getting irritated from these things. Okay, then also we can get oral cancer. So what is the TNM classification of oral cancer? So TNM classification. So whenever we are studying about any type of cancer, we are classifying the cancer into the TNM classification. So what is TNM? T stands for tumor, N stands for node, and M stands for metastasis. Okay, so every cancer has a TNM classification. So if you are not reading the TNM classification in the cancer, go and read about the TNM classification, because it is very necessary. Okay, so T is for primary tumor. If the TX is there, but means if primary tumor cannot be assessed, then we will give TX. If no evidence of primary tumor, then we will give T naught. If the carcinoma in situ means lip cancer, lip not cancer, but the cancer if started the oral cavity, whether it is in lip, whether it is in oral cavity, or whether it is in back of the oral cavity, if it getting cancerous, then we will give TS in situ. Then tumor 2 centimeter or less in greatest dimension, then we will give T1. If tumor becomes more than 2 centimeter but less than 4 centimeter, then we will give T2 marking. Then if tumor becomes more than 4 centimeter in greatest dimension, then we will give T3. If tumor invades through cortical bone into deep extrinsic muscle of tongue, maxillary sinus, or skin of faces, at that time we will give T4A. If tumor invades masticator space, tragoid plates, or skull base, or in cases internal carotid artery, then we will give T4B. Okay, so these markings are there. T, X, T, O, T naught, T is 1, 2, 3, 4, A, 4B. So we are we give marking on the basis of how the tumor we are finding or assessing. Okay, next is N means regional lymph nodes. So if regional lymph node cannot be assessed, it means NX. If no regional lymph node metastasis means metastasis not present in regional lymph node, then we will give N naught. If metastasis in a single ipsilateral lymph node or 3 centimeter or less in greater dimension, we will give N1. If metastasis in lymph node more than 3 centimeter but not more than 6 centimeter in greatest dimension, then we will give N2. If metastasis in a lymph node more than 6 centimeter in greatest dimension, then we will give N3. So lastly, our M, which is not the least because it is metastasis, it is the serious condition. Okay, so M naught means no distant metastasis. Distant metastasis, not only the nearby organs are affected, but distant, those who are far away from that organ, from that oral cavity, if they are getting infected, like lung cancer we are getting, and other laryngeal cancer we are getting, then only we can get M naught. Means M naught means M1 distant metastasis, and I'm not mean no distant metastasis. The cancer is confined only to the area only. Okay. So this is the TNM classification. Now we are moving to clinical manifestation. Clinical manifestation, as you can see in the picture, this can be seen during the oral cavity cancer. So firstly, if the patient is having lip cancer, what we will see? Indurated mass. Indurated mass means the mass collection in the lip only. Okay. Now, second is painless ulcer. We can see the painless, मतलब ulcer is there, छाले पड़ेंगे but वो पेनलेस होंगे, मतलब उनमें दर्द नहीं होगा. ठीक है. नेक्स्ट है टंग कैंसर. इफ द पर्सन इज हैविंग टंग कैंसर, देन what will be the manifestations? Ulcer or area of thickening. As you can see here, there is a ulcer. Yes, these are the area of thickening, right? Then soreness और pain, खट्टा सा फील होगा और दर्द होगा. ठीक है. इंक्रीज सैलिवेशन. सैलिवेशन इंक्रीज हो जाएगा, बहुत ज्यादा ही सलाइवा सिक्रीट होगा. स्लर्ड स्पीच होगी, स्पीच क्लियर नहीं होगी. ओके. डिस्फेजिया होगा, पेशेंट को क्या फील होगा? डिफिकल्टी होगी स्वेलोइंग करने में. टूथ एक होगा, दांतों में दर्द देखने को मिलेगा. ईयर एक हो सकता है. ईयर एक क्यों? क्योंकि वो मेटास्टासिस होके जाएगा, इस वजह से ईयर एक होगा. और ईयर एक क्या होगा? लेटर साइन होगा, इनिशियली नहीं प्रेजेंट होगा. ओके. Next, if the patient is having oral cavity cancer, then what will be the clinical manifestation? As you can see here, the whitish patches, which is also known as the smoker's patch or leukoplakia. Okay, so leukoplakia is also known as smoker patch. It is a white patch on the mouth mucosa or tongue, often considered as a precancerous lesion. Precancerous lesion इनको consider किया जाता है कैंसर होने के पहले. And less than 15% chances to transform into malignant cell. और 15% से कम chances होते हैं कि जो ल्यूकोप्लेकिया है वो क्या हो जाए? malignant cancer cells में convert हो जाए. ठीक है. The patch becomes keratinized, hard and leathery, and it's sometimes described as hyperkeratosis. Okay. So sometimes what happens? The white patch will be transformed or keratinized. मीन्स कैरेटिन प्रोटीन क्या होगी? वहां पे एक्युमुलेट होगी, जिसकी वजह से जो व्हाइट पैच होगा वो कैसा दिखने लगेगा? हार्ड, कठोर दिखेगा, लेदरी दिखेगा. ठीक है. जिससे हम इसको क्या कहेंगे? हाइपर कैराटोसिस. ओके. ल्यूकोप्लेकिया रिजल्ट्स फ्रॉम क्रोनिक इरिटेशन, स्पेशली फ्रॉम स्मोकिंग. ल्यूकोप्लेकिया ज्यादातर स्मोकिंग की वजह से जो कैंसर होते हैं उनमें देखने को ज्यादा मिलता है. ठीक है. बिकॉज ऑफ अ क्रोनिक इरिटेशन. नेक्स्ट, erythroplakia. As you can see in the picture, there is a reddish patch or red velvety patch you are seeing in the mouth or tongue. It is also a precancerous lesion, but there are more than 50% chances that erythroplakia may progress to squamous cell carcinoma of the oral cavity. Okay, so both leukoplakia and erythroplakia both are the precancerous lesion, but there are high chances that erythroplakia will be converted into what? Oral cavity cancer, which is mainly the squamous cell carcinoma. Okay. So other clinical manifestation what we will going to see in the oral cavity cancer is ulceration. छाले पड़ जाएंगे, rough area pain होगा, सर्वाइकल लिम्फ नोड इनलार्ज हो जाएगा, सोर स्पॉट होगा, कहीं कहीं पे खट्टा जैसा फील होगा, डिस्फेजिया होगा, डिफिकल्टी होगी स्वैलोइंग में, लम्प होगा, थिकनिंग चीक्स की साइड देखने को मिलेगा, एसिम्प्टोमेटिक नेक मास देखने को मिले जिसका कोई भी सिम्टम नहीं है बट नेक मास इज देयर। नॉन स्पेसिफिक साइंस हो सकते हैं जैसे कि सोर माउथ, वॉइस चेंज होगा, क्रोनिक सोर थ्रोट रहेगा। लेटर साइंस बाद में क्या देखने को मिलेगा, सोर थ्रोट और फीलिंग दैट समथिंग इज स्टक, ऐसा फील होगा कि कुछ गले में फंसा हुआ है, ठीक है। डिफिकल्टी होगी चूइंग में, स्पीकिंग में, ईटिंग में, ठीक है। देन हाउ वी आर गोइंग टू डायग्नोस दैट दिस इज only oral cancer, not any other cancer or not any cause of infection. So firstly what we will do, we will collect history. In history what we will get whether the person is having chain smoker, or whether the person is having frequent drinker, or whether this person is having hookah previously, frequently, like that, or he or she is exposed to UV rays so much. We are getting history from that, we can conclude something. Okay, then we will examine physically, we will examine all the organs, especially we will focus on the oral cavity. Then we will get a biopsy, we will take a biopsy. Biopsy is a tissue extraction or cell extraction from the oral cavity, and we will get to know whether it is a cancerous or precancerous or non-cancerous lesion. Then we will get oral exfoliative cytology. We will take a oral tissue, oral cavity tissue, and we will study on it. Then we can also take a toluidine blue test, where we will take our toluidine dye and we will assess by that. Okay, then we can also go for computed tomography scan, which is CT scan. We can also take MRI and positron emission test to diagnose oral cancer. So basically there are three main diagnostic tests, which is oral exfoliative cytology, toluidine blue test, and positron emission test. Okay, so what is its medical management? How we are going to manage it medically? See, this is a cancer, oral cavity cancer. So what we have to do, we have to give chemotherapeutic drugs. Okay, so what are the chemotherapeutic drugs we are going to give? It can be 5-FU, okay, methotrexate, cisplatin, carboplatin, bleomycin, and cetuximab. Okay, these are the chemotherapeutic drugs we can give. Then we can also give the radiation therapy. Then we will also medically managed by brachytherapy with implantation of radioactive seeds to the early stages of cancer. If we are implanting our radioactive seed, it will give radiation continuously and killing the cancerous cells. Then we will also provide nutritional therapy. Why? Because patient is having oral cavity cancer, he is not able to swallow or eat something, so he will be getting weight loss. Okay, he will getting malnutrition, he will getting weight loss, her immunity will be weak. So many disadvantages from that. So we are going to give nutritional therapy. We will see how we will going to give nutrition therapy. Then we will give as a, because it is a cancer. So what we have to do, we have to give a palliative care or palliative treatment. Then what is the surgical management we are going to do? Most effective on early stages, and the type of surgery depend on location and extent of tumor. Okay, so if we are doing surgical management in early stages, there is high chances we can treat the cancer. And what kind of surgery we are going to choose, it depends basically on the location where the cancer is located, whether it is lip cancer or oral cavity cancer or back of the oral cavity cancer, or the extent of tumor, whether it is 2 centimeter, 4 centimeter, or 6 centimeter. Depending on that, we will choose the surgical management. So our first surgical management will be partial mandibulectomy. Okay, if the surgery is of oral cavity, we can give the partial mandibulectomy. We will partially cut the mandible area and we will remove the cancerous cells, and we will do a plastic surgery after that. Okay, we can also do surgical management of hemiglossectomy, where we will halfly cut the tongue or the oral cavity of some part of the oral cavity, and we will treat the cancer. Then we can also go for glossectomy, where we will cut the tongue also. Then resection of buccal mucosa and floor of the mouth. We can resect or cut the some part of the buccal mucosa and floor of the mouth, and where the cancerous cells is present, and we will remove it out, and then we will give the plastic surgery. Then we can also, what I am just saying, reconstructive surgery or plastic surgery. After doing all the procedure, partial mandibulectomy or hemiglossectomy or glossectomy or resection of buccal mucosa, after this procedure we can go for the reconstructive surgery or plastic surgery. Next, radial neck dissection. If the cancer is of oropharynx, then we will also get the radial neck dissection. And if the cancer is metastasized, and then also we can give the radial neck dissection, which includes wide excision of the primary lesion with the removal of lymph nodes, the deep cervical lymph nodes and their lymphatic channels, and other structures may also be removed or transected depending on the extent of primary lesion. Means if the primary lesion is metastasized to oropharynx and nearby the lymph node, then we will dissect or we will excise the primary lesion with the regional lymph nodes. Okay, so radial neck dissection we can do. So what are the complications of oral cavity cancer? So first of all, mucositis. Mucositis means mucosa will be inflamed, xerostomia, dry mouth will be there, swelling will be there, stomatitis means infection of the oral cavity, and dysphagia will be there. Then nursing management, because we are a nurse, right? So we have to discuss about nursing management. We have to mainly focus on the nursing management. So first of all, what we will do, we will assess the patient condition, okay, and we will give them comfortable position, okay. Then we will monitor vital sign. We have to monitor vital sign 15 minutes or 30 minutes on 1 hourly, depending on the condition or seriousness of the patient. We have to monitor intake and output chart, because what patient is having intaking, that should be out. Okay, we have to monitor intake and output chart to balance the weight, because patient is getting weight loss because of dysphagia and of cancer also. Okay, then we have to administer medication as prescribed by physician. We have to follow all the rights of the medication. There are 16 rights of medication we have to follow, and we have to also do the 3 checks of the medication, right? Then we will administer analgesic as prescribed by physician. We can also placement of percutaneous endoscopic gastrostomy considered before radiation treatment or surgery. If the person is getting percutaneous endoscopic gastrostomy before radiation therapy, then we will also provide care for that. For parenteral fluids are given for first 24 to 48 hours. We have to give parenteral fluids for first 24 to 48 hours. After this time, internal nutrition via NG, gastrostomy or nasointestinal tube is provided. Means firstly what we have to do, we have to do parenteral fluids. No any fluid other than that. Only parenteral fluids for first 24 to 48 hours. Okay. After that, we can give internal nutrition like and from NG tube or gastrostomy tube or nasointestinal tube. We can give the internal nutrition. Okay. Frequent suctioning of oral cavity at time when swallowing becomes difficult. Whenever the swallowing becomes difficult, then we have to frequent suction of that. We have to observe for feeding tolerance and adjust the amount, time and formula if nausea, vomiting, diarrhea or distension occurs. We have to observe the feeding tolerance of the patient, whether the patient is having feeding tolerance. Then we have to adjust the time and amount and formula if the patient is having nausea, diarrhea, distension, abdominal distension or vomiting. At that time, we have to adjust that. We have to give small amount of water when the patient can swallow. After that only we can start the feeding. We have to observe for choking. If choking is present, we have to provide the abdominal thrust. We have to do suctioning whenever we are giving the feed or whenever the patient is drooling so much. At that time we have to suction, because we have to prevent aspiration, because patient is having dysphagia. We have to check the gag reflex also. Next, what is the nursing diagnosis? So here, imbalanced nutrition less than body requirement related to difficulty as swallowing as evidenced by weight loss. Okay. Patient is having chronic pain related to tumor as evidenced by patient facial expression. Ineffective health maintenance related to lack of knowledge of disease process as evidenced by poor oral hygiene. Okay, so where I have get these content from Richard Hempel, Dirksen, which is the Lewis book. Okay, and I have also taken the content from Cancer Government and Screening, IARC, and other FDI World Dental Organization. Okay, so this is all about oral cavity cancer. I hope you guys understand. So thank you so much for listening me, and please like, share and subscribe our channel. What? Anuraja Nursing Classes. Thank you so much.